So yes, thank you very much everybody for joining. There'll be some more people joining us as we go along. This is our final evening of doing a session as part of the so-called Eastern Cape Rural Health Onboarding Program, but it's not the end, it's just the end of this 6 weeks. And what's really lovely is we've been collaborating with the Worcester Family Medicine Department with Dr. Dylan Gibson, who's actually got weekly sessions that's going to be ongoing. And I think what's been the most exciting about this program is that nothing is ever lost. So every single presentation that we've had, including tonight's, will get recorded, will be put into on our website where it'll be easy to access. We'll send around the links. And so it's something that people can go back to or can be shared, or you can also use it to train people in your own facilities, or if you wanted to create discussion groups in your own facilities, especially on our more softer topics, then this material are always available. And I think COVID in this way has been such a blessing for training opportunities in rural health settings. Just a couple of housekeeping things. Please do keep yourselves on mute at all times. And then when we get towards, you'll see I'm going to do it into 3 parts, and we will record it as well as 3 parts. There will be questions at the end of each part, and you're welcome to add questions either to your chat, or you can develop, or you can add questions to your, just put your hand up if you want to ask something. So we'll make time for those. Zoom things are notoriously uninteractive, and one can do breakout rooms, but that's a whole nother art. Tonight it's going to be quite a didactic session. I've got a hunch it might take the full hour and a half. I fully understand if you can't manage an hour and a half of lecturing, and therefore they will be in 3 very distinct parts, and those parts will all be uploaded. So if you need to go at 7 o'clock because your kids are starving and getting frustrated, please feel free and see how much you can join in with us tonight. Also, it's always lovely to know who's joined us. We can't always see if it's your phone's name or whatever. So please in the chat, tell us where you're working at the moment, where you are from, and what you are doing there. So if you're a medical officer or clinical associate, or what your role is, and your name, please. So we would love to know at least who is on the call. So as I've said, we're actually going to do this in 3 different parts. And what I'm going to be doing is I'm going to be taking you on a journey through a whole lot of different types of approaches and ways to think about patient-centered care. And today I actually want to introduce a paradigm shift. And I think most of us don't even realize we're in a paradigm, and that it sometimes not necessarily has to shift, but can shift, and can be quite exciting when we make this shift. And so what I'm going to do is I'm going to be presenting you with lots of interesting things to think about during your consultation. And I'm going to encourage you to experiment with at least 1 or 2 things. So don't worry about the multitude of stuff I'm going to bring. You're going to pick and go, okay, that I can do, that I'm going to try in my consultation, and see what happens, see if something moves up. I'm also hoping that some of these tools you can have in your back pocket, where you have those consultations with a particularly difficult patient or a challenging patient, and then maybe these tools can help you with things. So there's a few provisos. The one is patient-centered care is not actually for everyone. So even though we're all a fan, even though we all think we're patient-centered, even though we all talk about patient-centered, it's a very different kind of style of working with patients, and it doesn't suit everybody's temperament, habits, or lifelong education or training. And there's nothing wrong with that. Doctor-centered care can still provide very good care, and both of these paradigms have limitations. It will also not automatically solve all your patient issues. So this is not, oh, wow, this is how we can manipulate our patient to do what we want. We can subtly influence. And therefore, it is one of those things that I'm hoping will improve things, but won't necessarily solve all problems. And the most important thing is that this paradigm is not easy. So I've been a fan of patient-centered care ever since I did my family medicine training, which was in 2003. This became my thing. This is what I was all about. I've been teaching on consultation skills for decades. And I would say on a good day at Nkobela Hospital in outpatients, I maybe do patient-centered care 20% of the time. And embarrassingly, even though I believe in this method, and even though I've been developing it over years, especially on busy days, It's not actually something that comes naturally. And it's partly because we've not been trained like this. This is not what you get modeled when you go and work in a hospital setting, or even when you've been seeing GPs yourself as a patient. And it's just one of those things that we've not catered for even as a medical profession, and especially not within our organizations. So everything with how we are set up within the Department of Health, and to a lesser extent, even within private practice, is around a doctor-centered care approach. And therefore, if you decide you want to work with a different paradigm and you want to try and do things differently, it's hard, because actually the surroundings that we've set up, the systems that we've set up, are not patient-centered. There we go. And very importantly, it's a lifelong journey. So my 20% is better than it was before, and I'm hoping to continuously improve that as I go along, because I really see the benefits of applying this as a process. So part one, we're going to do a little bit of background thinking, just a bit of the philosophy and some ideas around understanding patient-centered care before we're actually going to get into the nitty-gritty of taking us through a consultation and some helpful tools. And we've all heard this terms, patient-centered care versus doctor-centered care. And the first instinct would be, well, surely we're all patient-centered. It sounds terrible to not be a patient-centered doctor. I love that cartoon. You can see there's our patient in the middle, and there's all our colleagues busy looking things up or writing things down more often. And when quite often there's a whole lot of people working around the patient and helping the patient. So what do I mean when I say patient-centered care? So when we start at doctor-centered care, which is what we get taught at medical school, this is what we're all working in, this is certainly what my facility is all about, and I would call it the noble cause. There's nothing self-centered about patient-centered care. It's actually a cause that we get passed on to by our great professors at university. And the idea is that I shall diagnose the illness, or maybe the risk of the illness, and I will do so through examination, inquiry, and investigation. I will find out what's wrong with my patient. And then I will devise a suitable plan. I will come up with a treatment. I will come up with investigations. I will find out what we're going to do about this diagnosis. And my whole purpose is to restore my patient to health, to prevent complications, to prevent further disease, to prevent disease at all. And within this is a noble cause that we work towards. And if you think of our Department of Health, all of the things we do is working towards this noble cause. You know, when you've got all your files and you're ticking all those boxes, and all of those things we have to do to provide good care is based around this. But this is a doctor-centered model. And the reason why I'm calling it doctor-centered is because our focus is around the doctor's agenda. Now, sometimes our agenda and the patient's agenda might be in sync, but not always. So when we look at patient-centered care, and what do we mean when we say patient-centered care, that consultation, the whole focus is around the patient's agenda. So now I'm saying I shall identify my patient's agenda. And what's interesting is the patient does not always know what their agenda is. They are unwell. They have either symptoms or an illness or a funny blood test or something has been picked up, and they get worried. And these things that are happening to them has an effect on their life. It's affecting their work or their families or their children or the things they're trying to do. Things get out of sync. And out of this, they have something that they want to see changing. And so we will still use our skills, our examination, our inquiry, and our investigations. But what we're going to do is we're going to be assisting our patient with their agenda by coming up with a treatment plan together that's going to best serve what their particular concerns are about their symptoms. Now, in essence, a lot of stuff that happens in the consultation is the same in doctor-centered care and patient-centered care. You're still going to examine, you're still going to take a history, you're still going to come up with a prescription. But the paradigm that you're working from, the way you work in your consultation shifts completely when your focus is on the patient's agenda or the agenda that gets passed down through us as our medical prerogative, you know, all those guidelines and ideal clinics and all those things that we get told we need to do. So I'd like to tell a little story just to give an example of this. This is in the UK. So not common. This happens all over the world. And I was working as an NHS GP. This is also a good 15 years ago. And my father was also living in the UK at that point. And he was struggling with insomnia. Now, in the NHS is very similar to South Africa. It's also very doctor-centered set up. And the idea is that as a doctor, you get paid depending on how well you tick all these boxes. So the more patients you have over 60 that has had a blood pressure done, the more money you get paid, the more diabetics who's controlled, the more money you get paid, etc. So a lot of recording to make sure we meet all those targets. My dad had been struggling with sleeping for a while, and my mother had been nagging, you know, dads and men don't like going to the doctors. And so finally she'd convinced him, called up, made an appointment, shoved him out the door, and he arrived at the GP. So that evening I'm calling up, great, you know, what did the doctors say? What came up? We're all worried as one is. And my dad was like, no, very nice doctor, very kind, very lovely. We had a lovely chat and he did a full health check. He checked my blood pressure, did my weight, we checked my cholesterol. It was very thorough. And I'm like, but Dad, what about the insomnia? Oh, he said not to worry about it. And this kind of thing happens repeatedly, that the patient comes in with something and can get actually carried away. I'm quite sure my dad did not protest too strongly when they went down the doctor's agenda for the day. So I think one of the challenges, or one of the things that happens when our patient comes through the door, is we're assuming that our agendas are the same. We're assuming that what the patient sees is already what, and they've just come in like a blank slate. But what's very strongly informing the way our patient is looking at our consultation is their own health beliefs. And I'm going to look at two sides. I'm going to look at major paradigms that are in existence around understanding patient health beliefs. And then I'm also going to look at some of the individual factors that come into play. Now, you will notice I'm going to be drawing on a lot of gurus, masters, people whose shoulders I stand on in terms of particular perspectives that has made a huge difference also to myself, and is also standard practice within family medicine of helping us understand patient-centered care. This is a non-medical approach that is very useful within medicine and is very well described in a book called The Theory of Everything by Ken Wilbur. And he talks about paradigms as well in terms of communities. So different people, we all grow up in different communities, and in the families and the communities we grow up in, we might have different paradigms depending on where we live and how we look at the world. And it affects the way we think about everything in terms of what is important to us, how we understand how the world works. And it also influences the way we understand health. Now, the challenge with paradigms is they're just different perspectives and they belong to different communities, but we all tend to think that our paradigm is the correct one and, you know, everybody else will eventually get there. But of course, you can't judge paradigms as incorrect or correct or better or worse. They're just perspectives. It's like different pairs of glasses that people wear. So for example, if you have an elderly gogo living in a rural village out near Lusikisiki, she's built her own little hut. She grows her own millies in her own vegetable garden. She smokes one of those lovely pipes. She doesn't speak a word of English. And she's lived in that village her entire life. She might come from a paradigm where nature is seen as being a very powerful, inexplicable force, where one has very little control over one's own health. And there's a huge belief in the world of the supernatural forces that can affect your health. So either through curses, through angering the ancestors, and how one mediates that is usually working through the traditional healers and working with these spiritual beings to be able to restore health. So I once had a patient at Nkobela, for example, with TB, and we were struggling to mobilize him. He wouldn't walk because he had this very painful foot. And we had investigated and examined and did everything with his foot you possibly can. It didn't look like a plantar fasciitis. We couldn't find any specific, but he certainly couldn't step on this foot. It was way too painful. And of course, only a few weeks down the line, you properly sit down and ask him, well, what do you think it is? And he then tells us a story that he had stepped on muti that was put in his house, which he think was put there by his brother-in-law. And this was causing the problem with his foot. So at that point, it was clear that I was not the right person to help him, and we therefore discharged him and referred him to his traditional healer to assist him with that. So that's one possible paradigm. Another paradigm would be also quite often from your more rural villages, but this feeling of helplessness in terms of nature being so powerful, especially your young boys. There's a feeling that um, I can overpower nature through pure physical strength and health. So there was a great book written a few years ago called The Three-Letter Plague, many years ago now, when they started the first HIV programs in Lusikisiki. It was written by a journalist who was trying to figure out why, when they now for the first time had ARVs available and HIV testing available, did so few men get tested. So he actually spent some time with some of the men in the village. And he gives this beautiful picture of this very strong perspective that if I am well and if I'm strong, I shouldn't be able to get sick. It's been one of our challenges, for example, with the traditional circumcision ceremonies, that there is a belief within this paradigm that if I get sick, if I get septic, or if I get dehydrated, or if I get unwell, that is a sign of weakness in myself. I am physically or morally or as a person not strong enough, and therefore will not admit very easily to for example, feeling unwell. So in this kind of a thing, the very idea of having HIV in your blood is unacceptable. And having a test done feels unacceptable because it feels like you are yourself being defined as weak. So if we move a little bit to the suburbs, one gets a paradigm where there's a very strong relationship to more that hierarchical, bureaucratic organizations, larger organizations, much more stronger relationship to religion, quite often a much stronger relationship to conscience. And there's quite often very strong relationships through prayer towards illness and healing. Now, what's interesting is not everybody that's religious necessarily look at illness through this paradigm. And also quite interestingly, people can be between different paradigms. So when you go home on the weekends, the paradigm you look at through illness is to do with your own religious beliefs. But when you're at work as a doctor, for example, then we can look at it through more the orange paradigm, which is all about well-researched, evidence-based medicine. And we're now moving into the scientific way of looking at the world, commercialism, consumerism, etc. Blue and orange is the two predominant paradigms in South Africa today, and people quite often relate to both these paradigms in different scenarios. And again, it's very important, neither of these are wrong or right. But please note that every single thing that we publish or create to inform patients about their health is done through the orange paradigm. There's one more that I'm describing here, although there's very many layers, different layers that he describes in the book, but these are the main ones. And these are people who are starting to look larger at the more sort of global effects of consumerism, of science advancement, I guess, and start going back to the idea that we as human beings should be able to strengthen our own immune systems, should be able to strengthen our own health. Socioeconomic factors becomes important. You have all your advocacy and your green groups, your vegans, vegetarians, and also people who more and more start exploring homeopathy, alternative chiropractors, acupuncture, and alternative means, trying to strengthen and work with health and healing in a whole. Now, the challenge is when your patient comes in, we're sitting from an orange perspective. Everything we're explaining to our patient comes through an orange perspective. Even if you yourself are quite more blue inclined in your paradigm or more green in your paradigm, when we talk to our patients, that's the tools we have. Those posters that we put up in our offices are all in orange language. If you've got a patient sitting in front of you who is coming from a purple paradigm or a red paradigm, quite often what you are saying, even though they can understand the words, they can even make sense, they've heard it all before on television, or they've heard it all before in various, and it's even at school or in education, they don't relate to what we're saying. It's not so much that we suddenly have to find ways of how to explain things to the different paradigms, but being aware of this gap is very important when we start engaging our patients and listening to what's going on for our patients. And how to create a consulting room where we can actually give them the possibility to say, well, I think I was cursed and that is why I have this illness. So that's paradigms, that's communities that our patients come from, but our patients also have their own stories. So no one is a blank slate. So I just want to imagine yourself for a moment, sitting yourself in a scenario where you're in a waiting room waiting for a doctor. And I went through this not directly, but in October of last year, my daughter developed type 1 diabetes, and we ended up with her in DKA in an ICU in a life hospital. And so suddenly I was on the other side of the consulting table, so to speak. And what you realize is when you go to see the doctor, the pediatrician was lovely and she was a good friend of mine, but you're nervous and you're worried. And even though I knew all the science, I was still nervous and worried. And what happens is before you see the doctor, as you know, she's going to come at 9 o'clock for a ward round, or when we've been waiting in outpatients, your mind starts going through this commentary. And quite often when we're sitting, looking at our patients in the waiting room, we assume they're all sitting blankly, waiting. But of course, they're all sitting there and their minds are already ticking over. And there's all kinds of different things they can think about. So they might be worried about what their symptoms are or what's going to happen with it. They might be worried about who they can told or who they haven't told, if they're worried about something like HIV. They might go through all the things they must remember to ask the doctor or must remember to tell the doctor. They might also have all the other stuff that has to happen. They're worried about how long the consultation is going to be. They need to get out of here by this time. They're worried about their transport back home. And then there might be larger issues in their life that's going on. They might be in a massive relationship problem. They might be struggling at work. They might be struggling with massive poverty and food shortages. And all of these things goes through their minds in different bits of importance, depending on their story, before they come and see you. And so when they walk in, all of this already underlyingly creates an agenda. There's something that they hope is going to happen in this consultation. And it's not always even clear to themselves. Sometimes they can be very confused and overwhelmed by what is happening. So that's a little bit just starting to understand that our patient's not a blank slate, and we're going to come back to it when we go through the consultation and how we help elicit those health beliefs. The second little bit I want to talk about is the talk's name was How We Influence Our Patients. And I want to talk a little bit about how we create a receptive mode for our patients to actually listen. And to be able to do that, I have to share a little bit of neuroscience. Now, I've shared this already in the Thriving to Rural Health presentation. So those of you who are interested, you're very welcome to watch those. They're also on my YouTube channel. And it looks a little bit at how stress affects the way we think. So just a recap, and it's going to be a very short 3 slides recap. We're all aware of how stress affects our physical bodies when we are a little bit nervous or a little bit worried, that we create this fight, flight, freeze response. We're all very aware of that. And we know that our heartbeats go faster and we breathe faster and all of those things. What we don't focus on so much is how it changes the brain. So when you have adrenaline in your body, it switches the way that the brain functions. And in the brain, you have your major cerebral cortex with all the different skills. There's quite a nice, you can use a hand to describe the brain. That's the limbic brain sitting in the middle. There's your cortexes on the side. There's your prefrontal brain sitting here. And when we are stressed, then this limbic brain is what creates is in charge. It's the one that decides what needs to happen because it's all about survival. So if we're feeling slightly threatened, the limbic system comes into play and it changes the way we think. I like to call this the street view because we have no perspective. You know those video games where you see the guy in the little narrow village with his gun, and he has to just figure out moment by moment what he's going to do. And at that time, when one is stressed, you don't have much access to your higher functions. You're primarily looking at how to survive and manage that moment. If you are completely relaxed, then we are using our prefrontal brain to make our decisions, and we're now in a more creative mode. And this is much more where our limbic system is focused on survival. Our prefrontal cortex is more focused on meaning and purpose and seeing the larger picture. That's what I call the balcony view. That's when we're able to look at a situation and get perspective on what's actually going on. And here lives all our creative, innovative, and high intelligent functions. So the next man I'd like to mention in terms of great books, for those of you who do like to read, Prof. Steve Peters wrote an excellent book called The CHIMP Paradox. where he describes these two different parts of the brain. And we've got a lovely little picture here on the left of, you can see there's the limbic brain, and he calls this the chimp part of ourselves. So when we are slightly stressed and our limbic brain is in charge, we are in chimp mode. We are sort of in an animal mode. It's all about survival, and we're going to look at how the thinking works for that. Where here, if we are relaxed, creative, limbic system, our chimps on leash and nice and relaxed, then we can access our higher sage self, if you want to put it, our higher intelligence self, and that is how run through the prefrontal cortex. So if you look at how much thinking changes depending on which mode you're in, if you're in chimp mode, your thinking is very emotional. You guess, you tend to fill in detail using assumptions. So all of our biases lie here. You can imagine if you're stressed, you've got to make decisions very quickly about solving an issue. So instead of thinking very clearly and being able to see the whole picture, you're going to make it up as you go along. This thinking can be very unstable. It can be inconsistent. And one of its favorite exercises is jumping to an opinion or jumping to a conclusion. So social media is full of chimps having their little says about every single thing that comes into their minds without necessarily thinking it through. It thinks very much in black and white. So whenever you have somebody who's I'm right and you wrong, or you have thinking that's very judgmental, you are in chimp mode. It has to be paranoid. Remember, it's a survival function. It's always going to look for the negative. It's always going to look for the worst case scenario. And this big thing is it's extraordinarily judgmental. It judges without favor, without thinking things through. And here lies all of our bases for prejudice, racism, intolerance lies within this chimp mode, within this mode, which is actually just what we are doing when we're scared. If we are in sage mode, then suddenly we're able to access our prefrontal thinking, and we're able to access our conscience and our empathy. So now we're not using emotions to make decisions. We're interpreting information through facts and truth. Now we can think something through rationally and logically, and not just how I feel about it, but okay, what is true and what is not true here. Now you can finally find context and have perspective. You can see those shades of gray. It's not always black and white. Find a more of a balanced judgment. This is where all our possibility for empathy and compassion lies, our ability to step into somebody else's shoes. This is where we go when we're creative, when we're innovative, when we come up with solutions. And I love this word. This is from Brene Brown. The word generous in assumptions, which meaning that if somebody else behaves badly, if they're flipping their lid and they're shouting and they're screaming and they're ranting and they're judging and they're criticizing and they're emotional, to be able to realize, oh, no, they're probably not safe. They're probably not like that as people. The moment they're just a little bit freaked out, and to be generous, to not judge people as harshly as we do, and therefore also not judge ourselves so harshly. This ability to recognize when we're in chimp and sage mode is very important in ourselves, and also to recognize it in those people around us, because we all have this, we all do this. And the big thing to realize is that when somebody is in chimp mode and so behaving badly, that they are actually frightened. They're feeling anxious or worried or threatened, and that's why they're behaving in that way. So when we look at what triggers the chimp, it's always got to do with safety. And it's sort of helpful to understand sometimes what kind of thing might have triggered it. So you all remember the Maslow triangle. And I'm going to look at just 3 of those levels. So there's a need to be safe bodily. That's our safety needs and our physiological needs. So we're not physically threatened. Chimp definitely gets triggered when your car swerves in front of you. And what's great with the chimp, it's very good in survival situations. It thinks very quickly, it makes quick decisions, and it's helpful when you're fighting for your life. But the next level is we also need to be safe emotionally. We need to feel that we're part of a family, that we're not being excluded, that we're not being pushed out, that we're not being ignored. And then we also have a need to be able to make independent choices in our lives and live the kinds of lives that we would like to live, that freedom of choice. Now, when your patient comes in to see you, they are already feeling a little bit unsafe. They're having bodily symptoms. They're already scared and nervous. They're already feeling slightly threatened, and they're already slightly more in chimp mode. They're not sure what the doctor is going to do to them. And I imagine if you've got a patient who's just missed 3 months of treatment and the nurse has been calling him to come in, he's arriving and he's terrified. And what we want to do, the problem is when you're talking to somebody who's terrified, you're only talking to the chimp. You're not talking to a rational human being. And you're going to really struggle to come up with some solutions with that patient. So we want to start looking at how do we create a consultation where the patient feels safe and when we are able to actually elicit those particular things. What I'm going to do now, this is our first part. That's given us a bit of background. We're going to start moving into some of the actual things in the consultation now. And I just want to see if there's any questions at this point. I'm going to pop to the chat. I see there's a bit of sound